Do you remember what your number one priority intervention is for a GI bleed patient? And if you didn't immediately think IV fluids, then you need to watch this video because we are going to cover 3 frequent flyer NCLEX topics. That's GERD, peptic ulcer disease, and GI bleed. So GERD, or gastroesophageal reflux disease, occurs when you've got a weak lower esophageal sphincter. So normally this sphincter should close tightly and prevent the backflow of gastric acid and stomach contents into the esophagus. But in GERD, that lower esophageal sphincter, or LES, becomes weak, and that acid can just reflux right into the esophagus, and this is going to lead to irritation, inflammation over time. Even it can cause strictures and esophageal cancer. So what are you going to see if your patient has this condition? Well, this is going to cause symptoms you would pretty much expect if you have acid refluxing into the esophagus. So that's going to create a sense of heartburn, that epigastric sort of discomfort after eating, a sour taste of stomach acid in the back of their throat, and it can cause cough and can even cause epigastric or chest pain that might mimic angina or an MI. So don't miss this one. And typically this is going to be worse with anything that's going to increase abdominal distension, like big meals, or bending over or lying flat is of course going to worsen that reflux up through the LES. So if your patient does have heartburn or epigastric pain that's worse after meals, what are we going to teach them? Well, you're going to want to teach them to avoid triggers. The big ones being anything that's going to irritate the stomach. So gastric irritants are spicy foods and anything acidic like citrus or tomatoes. They should avoid other GERD triggers which tend to weaken the lower esophageal sphincter more, which is going to be caffeine, peppermint, and chocolate. So although they have that sour taste in their throat, they should not suck on a peppermint because that's just going to weaken the lower esophageal sphincter. And the big 3 to avoid are going to be easy to remember with this mnemonic FAT. So they want to avoid fat triggers. That's fatty foods, alcohol, and tobacco. And of course, because this is a problem of stomach contents refluxing into the esophagus, we need to teach them to stay upright after meals. But do you remember for how long? So that's going to be for 3 hours after meals. They want to stay upright and they shouldn't lay flat. And when it is time to lay down to go to bed, try to keep the head of the bed elevated if they can. And if those lifestyle changes fail, we have other interventions that we can use as well, namely medications. So those are going to be our acid controlling meds like proton pump inhibitors, so pantoprazole, esomeprazole, anything that ends in prazole, and H2 blockers like ranitidine, famotidine. Those are going to be taken on a daily basis to lower the acid in the stomach and decrease the damage to that esophagus. And then our antacids like calcium carbonate, that's Tums, and magnesium hydroxide, that's milk of magnesia. Those are taken on an as-needed basis to relieve the symptoms of heartburn after meals. And then if that still isn't enough to manage it, we have some procedures that can be done as well. So namely a fundoplication, that's going to be this surgical tightening of the lower esophageal sphincter to prevent that backflow. And there's actually something called a LINX procedure, which creates this sort of little metal magnetic bracelet-like thing that's going to close and open to allow food to enter when they're eating, but then is going to close up behind it to prevent that reflux. But because we're literally implanting magnets into the stomach, you need to teach these patients that the LINX device is not MRI safe, and so they cannot have any MRIs once they've had the LINX implanted. So for our NCLEX quick check on GERD, what can GERD symptoms mimic? And that's going to be angina or MI. So if a patient comes in with epigastric pain that's worse after meals, but they don't have any risk factors for heart disease, this could be GERD. Next, what 3 major triggers should patients with GERD avoid? And remember your fat triggers. That's going to be fatty foods, alcohol, and tobacco. And finally, what should clients with GERD wait to do after meals? And that's going to be to lay flat. They need to sit upright for at least 3 hours and keep the head of the bed elevated if they can. So next is peptic ulcer disease. And this is also a problem of stomach acid. But unlike with GERD, this isn't where gastric acid refluxes into the esophagus, but rather that gastric acid is actually going to break down and along with pepsin digest the inner lining of the GI tract. So this can happen in either the stomach, and we would call those gastric ulcers, or in the first part of the intestines called the duodenum, and we would call those duodenal ulcers. And this can have several underlying causes, but 2 of the big ones to know for NCLEX are going to be H. pylori, that is a chronic stomach infection, and NSAIDs, NSAIDs because taking ibuprofen or aspirin for a headache every day is actually going to weaken the lining of the stomach wall. How do we know that our patient has these craters essentially being burned into their stomach? Well, they're going to have burning, gnawing pain, but whether it comes on or is relieved with meals is going to depend on the site. So if they've got gastric ulcers, that's going to worsen after eating because eating is going to increase acid secretion in the stomach and worsen that pain, whereas duodenal ulcers are actually relieved by eating. So don't forget the difference on NCLEX. So these would be our expected findings with peptic ulcer disease. But if an ulcer ruptures, it can actually cause peritonitis. So watch for these red flags of perforation and rupture, which is going to be a rigid board-like abdomen from that inflammation of the peritoneal cavity, or even signs of GI bleed if those ulcers bleed, which is going to be tarry stools. And because peptic ulcers are in the stomach or the duodenum, this can be diagnosed with an upper endoscopy, also called an esophagogastroduodenoscopy. Say that 3 times fast. But just use the name to help you. This is going to go here through the esophagus into the stomach and look at the duodenum. And this can be used to visualize those peptic ulcers. But because this goes through the patient's mouth, we actually have to use a numbing spray in the back of their throat. So you want to be sure to monitor for the return of the gag reflex and keep them NPO after the procedure until the gag reflex returns, or they could aspirate. So once those peptic ulcers are diagnosed, what do we do? Well, it's going to be a lot of the same interventions as we would do for GERD because it's still a problem related to stomach acid. So we would teach them to follow a bland diet and avoid a lot of those same irritants like caffeine, alcohol, and spicy food. Another important teaching point is that they should avoid taking NSAIDs. So some people might think, I've got a stomach ache, I'm going to take an ibuprofen, but ibuprofen, naproxen, aspirin, those are all going to weaken the stomach lining and make this problem worse. So these patients should only take Tylenol for pain. And because stress is a big contributor to these peptic ulcers, we want to teach them stress management techniques like deep breathing and guided imagery as well. And then a lot of the same medications are useful here. So PPIs, H2 blockers are taken on a daily basis, antacids are taken as needed, and then we can also give sucralfate or bismuth subsalicylate, that's Pepto-Bismol, and this is going to coat the inside of the stomach lining and protect those ulcers during meals and at night when gastric acid secretion is highest. And if H. pylori is the underlying cause, then they're going to get a course of antibiotics to treat that H. pylori as well. So next for our NCLEX quick check on peptic ulcer disease and endoscopy. So pain from which kind of peptic ulcers is going to worsen after eating? Is that gastric or duodenal ulcers? And this is going to be pain from gastric ulcers because remember, eating is going to increase stomach acid secretion and increase that pain, whereas duodenal ulcer pain is relieved after eating. And what warning signs of ulcer perforation should you monitor for? And that's going to be that rigid board-like abdomen is classic for ulcer perforation and peritonitis. And what foods and medications should clients with peptic ulcer disease avoid? They're going to avoid any gastric irritants like caffeine, alcohol, and spicy food, and they need to avoid NSAIDs like ibuprofen or aspirin, which weaken the stomach lining. And finally, what should you monitor for after an EGD? That's going to be for the return of the gag reflex, and you'll want to keep them NPO until that gag reflex returns. And now for the big, scary GI bleeding. And the NCLEX thinks you're not going to take this seriously because you're going to treat it like a digestion issue instead of a circulation issue, but GI bleeding is a life-threatening cause of hemorrhagic shock. So don't miss these signs. And how it shows up is going to depend on what part of the GI tract is bleeding. So an upper GI bleed is going to present differently from a lower GI bleed. And an upper GI bleed, because the bleeding is so close to the top of the GI tract and the mouth, it's either going to show up as hematemesis or that frank bloody red emesis, or melena, those dark tarry stools. And this is because that blood has had time to digest as it passes through the GI tract and gives it that dark tarry appearance. Whereas bleeding from the lower GI tract is going to show up as hematochezia or brighter red blood in the stool. And of course, if either of these is severe enough, it can cause hemorrhagic shock. And so this is going to look like changes in our vital signs. And do you remember what we'd see? Well, not only would we see a low blood pressure, but an increased heart rate because that's compensatory. And because they don't have enough perfusion to their brain and their skin, that's going to show up as altered mental status and pallor. And if we draw labs, we're going to see a decreased H&H, and monitor their urine output, we're going to see decreased urine output as well because they aren't getting enough blood flow to their kidneys. So if your patient with a GI bleed has altered mental status and melena, and then our H&H shows that they're really anemic, do you remember what your number one priority intervention should be? Say it with me, it's going to be an isotonic IV fluid bolus. Remember, this is a circulation issue and we need to restore circulating blood volume ASAP, and giving IV fluids is the fastest way to do that. Of course, we're going to draw their H&H and monitor that, and also while you're already getting blood, go ahead and get a type and cross match because we want to anticipate transfusion if the bleeding doesn't stop. So the way that we would stop that bleeding is going to be with an endoscopy. So while we're getting everything ready for an endoscopy, we're going to continue to monitor those things that told us they had a GI bleed in the first place. So not just their stools, but also their vital signs, their mental status, and their urine output. So if they had melena, would they need an upper or a lower endoscopy? And melena, remember, is an upper GI bleed, so that patient would get an endoscopy. But if they had signs of a lower GI bleed, like hematochezia or blood in the stool, they would get a lower endoscopy. And so this is very similar to the upper endoscopy, except instead of going through the EGD route, it's going to go through the rectum and actually visualize the colon. And that will let them band, clip, or cauterize any bleeding that they see there. But although any kind of endoscopy can cause a perforation, the risk is slightly higher with a lower endoscopy, so we're going to want to monitor for perforation afterward. And remember, that's going to be that rigid board-like abdomen, which is a sign of inflammation in the peritoneum because that perforation causes intestinal contents to spill into the peritoneal cavity. Now for our final NCLEX quick check on a GI bleed. Melena would indicate what kind of GI bleed, upper or lower? And remember, melena is dark, tarry, digested blood because it came from an upper GI bleed. And what's your number one priority intervention for GI bleed? You should know it by now. It's isotonic IV fluid bolus. Good job. Which labs do we draw for GI bleed? Not just the H&H, but also a type and cross match to prepare for transfusion. And now you're ready for GERD, peptic ulcer disease, and GI bleed on the NCLEX.